Good morning from Miami Beach, home of Neurosurgical TV. We are honored with the a series of webcasts on neuroendoscopy, chaired by Dr. Y.R. Yadav, the president of the Neurological Society of India. And I'm going to turn it over to Dr. Narayan Swami, a neurosurgeon from Mumbai, I believe. He's going to run the proceedings. Welcome, Dr.
Thank
Swami.
you. Thank you. Good evening, everybody, and good morning to the other parts of the world. So I welcome you again to sixth in the series, to be presented by none other than Professor Yadav, who is the present president of Neurosurgical Society of India, who has got wide publication, just got more than 10,000 citations of him, and then he has been a teacher throughout his life. He has got a number of workshops in premier neurosurgical institutes as well as cadaveric dissection. He has written articles, numerous articles. He has written textbooks. He has trained more than 850 neurosurgeons, and he has been practicing wonders. Today, he is going to speak on endoscopic removal of the deep-seated hematoma as well as the brain tumors by using tubular retractor, means taking the assistance of tubular retractors. We are also joined by neurosurgeons of excellent caliber, Dr. Avdesh Jaiswal, who is known throughout India and the world, who has been going to all webinars and demonstrations, a excellent neuroendoscopic surgeon, and Dr. Jaiswal, Dr. Jitin Bajaj, who is working in Jabalpur Medical College, and then who is a very enthusiastic neurosurgeon, and then who has represented a lot of innovations, and then who has gone to America and showed his work. He can do almost all neurosurgical work with a lot of ease and not wasting more time. So I invite Professor Yadav to continue his lecture, please.
Thank you, Professor Narayan Swami, for kind words. I'll share my screen. So, this talk is divided into two things. One is the deep-seated brain tumors, including intraventricular tumors, and another is deep-seated hematomas, hypertensive, thalamic, and basal ganglionic hematoma. Greetings from India. So this is endoscopic removal of deep-seated brain tumors using tubular retractor. So I'll come on to why tubular retractor. I know Professor Jaiswal does excellent work, and he does not use any retractors. So there are other ways also, and excellent ways, and good outcome. Another way of doing things, we should all know what are the various methods you can do things. So endoscopic approach and tubular retractor and the large tumors. We usually think that only as far as the endoscopy goes, then it is usually suited only for small tumors, avascular tumors, but with the combination of tubular retractor and endoscope, we can do even large tumors, which usually most of us do with the microscope. So, nothing to share except that I'll be talking a tubular retractor, which we devise. Although I don't hold any share, or I don't even market that tubular retractor, it's freely available. And I think it is one of the very good, one of the tubular retractors which can be used in the endoscopic surgery. So deep-seated intraparenchymal or intraventricular brain tumors are difficult to remove. Is my voice all right? Is there any disturbance? I think my AC, I'll stop that. Is
You're
there
okay, sir.
any disturbance?
It's okay.
It's okay. Okay. So, deep-seated intraparenchymal or intraventricular brain tumors are difficult to remove. The difficulty are because of to maintain the corridor, especially when it is deep-seated. So you have to retract the overlying brain. So to maintain corridor is little bit of challenge without harming the overlying brain, and there may be risk of injury to the overlying brain when you retract using different methods, whether you use a tubular retractor or the conventional LELA retractor. So if you use tubular retractor, then possibly the injury to the overlying brain parenchyma can be avoided. This is what I'll be discussing. Usually when there is a deep-seated lesion, there is a poor visualization when you use microscope, especially of the corners. So, for example, if this is the corridor and if you want to visualize this part of the tumor, then it is difficult. You have to either widen the corridor, thereby you increase the amount of damage to the brain parenchyma. But when you use either a long axis or endoscope, angle endoscope, then even with the same corridor, you can visualize the whole extent of the tumor. Same here. So one should choose long axis of the tumor, and also if you use endoscope. So using an endoscope, the long axis, that means choosing a correct trajectory, and with the endoscope, you can overcome all the difficulties which may be there. This is one example. If the tumor is like this, always you don't come across tumor which will be according to what you want. So at times it may be elliptical. So choose a long axis of the tumor so that with a small corridor you can approach the tumor. Not only it may not be close to the, it may not be shortest way of approaching that, but the long axis is one, and obviously you should not go through the allocant area, or you should not damage the white matter tracts. So that we'll be discussing. We all know that there are endoscopic techniques. One is the channel endoscopic surgery. Usual methods of endoscopic surgery is that we pass instrument through the working channel as shown here, and therefore there is a difficulty in bimanual dissection. Usually one instrument is passed, but you can pass even two instruments through the working channel, usually under the liquid media. So if there is a bleeding, or you require a good bimanual dissection for lesions to detach it from the other vital structures, it is difficult using channel endoscopic surgery. So channel endoscopic surgery is usually indicated when the lesion is small and avascular. So using one single working channel, you do the surgery. Whereas if you use port or the tubular retractor, this is also pure endoscopic surgery. Microscope is not required. The instruments are passed by the side of the endoscope. So the tube is there. You station endoscope there at the one corner of the tube, that is tubular retractor, and then you pass instrument by the side of the endoscope. So it is a port system surgery or tubular retractor surgery. There is no difficulty in manipulation of the instruments. You can pass instrument at the angle you want, whereas in channel endoscopic surgery, the angle at which you pass instrument is decided by the channel of the endoscope. So here you can have any angulation. So good bimanual dissection is possible, and you can do surgery through the air media, and therefore there is no difficulty in controlling bleeding as is there in microscope. So there are advantages of microscopic surgery and there are advantages of endoscope. So both advantages are combined, and therefore you can operate large and vascular lesions using tubular retractor with the help of endoscope. And this is what I'll be discussing today. So combination of endoscope and tubular retractor can overcome the difficulties which one come across in channel endoscopic surgery or even in microscope. So there is no difficulty in bimanual dissection. The bleeding can be controlled, large and vascular lesions can be approached, and you have no problem in visualization of the corner. As against microscope, the endoscope allows you to see at the corner. So all the difficulties which are there in microscope or in the channel endoscopy can be overcome using this. Regarding the tubular retractor, we all know that tubular retractors are better compared to, I mean, if possible, you don't use the retractor, but if you have to use the retractor, then tubular retractors are better than the LELA retractor. The tubular retractors, they exert less pressure on the brain, and it is unlikely to cause damage to the overlying brain. And this low pressure on the brain is because the pressure is distributed in all the direction, as against only a focal pressure by the LELA retractor, and it is on the large surface area. Therefore, the pressure on the unit area is less. Although there are many tubular retractors available, but they are costly. These are rigid in nature, therefore can produce trauma to the brain. They need comparatively large opening to reach the site of interest. Some of them, they require holder. There is a time wastage in locking and unlocking of the holder, and some of them have opaque wall. Therefore, you are not able to visualize the surrounding brain, and comparatively heavier. The tubular retractor which we devise is unique in two respects. One is that there is a longitudinal cut on the tubular retractor. So this longitudinal cut allows great advantage. One is that it can be folded. So when you want to introduce it in the brain, then you fold the tubular retractor and introduce it. So you can introduce the tubular retractor through the small opening. And the second advantage is that when there is a raised ICP, then the other tubular retractor, because they are not able to fold, therefore they cause pressure on the surrounding brain. But this tubular retractor folds on itself. So when there is a raised ICP, it becomes a small, it gets folded up. And when you keep on removing tumor, it opens up gradually. And it is soft, made of silicone, therefore it is unlikely to cause damage. So damage to the brain. So these two properties, longitudinal cut and the soft nature made of silicone, allows it to be one of the noble tubular retractor available. And the third thing is that the cost is almost nil. So that is another advantage. So the advantage of our tubular retractors, it dynamically changes the size as it is required. Initially with the raised ICP, it is small, then it keeps on expanding. It is inexpensive, simple, helps in controlling bleeding. If there is a bleeding from the floor of the tumor bed, then you gently push it down. The tubular retractor just gently push it down, and it causes tamponade effect on the vessel which is bleeding, so bleeding stops. Requires very small brain opening, and when you push it down, it does not damage brain also. So without damaging the brain, it causes tamponade effect on the vessel, and therefore it controls bleeding also. It requires a small opening, it is soft, therefore does not produce trauma to the brain, effective and safe. It protects brain, so it provides lining over the overlying brain parenchyma, so does not cause, it does not allow thermal damage because of the endoscope. There is a heat generation in the endoscope, so that temperature generation of the endoscope does not damage the surrounding brain, because there is a tubular retractor in between. And when you introduce instrument or take out the instrument, that also, it protects brain from accidental injury from the instrument introduction and removal. Although it should not happen with the kind of work we do, none of the surgeons should be doing that. It is lightweighted, can be moved in any direction. There is no need for any holder. It is transparent tube, so it allows the surrounding brain or the tumor to be observed. In the technique, for example, if there is a tumor, deep-seated tumor in thalamus, so either you use image guidance to find out which trajectory you want to take, and also the tractography, or you can use intraoperative USG to find out the trajectory. Or when these things are not available, we used to do even pre-operative CT or MRI, and you can use marker CT. See, this is the marker. So at the center of the tumor, you put in marker there, and then so this was the marker. We have marked it on the skin, and you plan the incision at the superior parietal lobule, and then you can decide, because this is the center of the tumor, so you can decide the trajectory in which direction, and you can find out the depth at which you will find the center of the tumor. So even without very high-tech facility, you can operate, and this is what we have been doing, because we did not have image guidance for some time, although we have now. So even with the marker CT or MRI, you can find out, you mark the center of the tumor, decide the trajectory, and decide the incision where you want to make. Although adjuvant facilities, if you have, then it adds to the safety. Image guidance, if you have, it is nice. Intraoperative MRI, intraoperative USG, 5 ALA, fluorescence, awake craniotomy, neuro monitoring using MEP, or so this will allow safety in surgery. And the tractography also is quite useful, because the tumor can displace the important tract medially, laterally, superiorly, or inferiorly. So that all these things you need to know before surgery. Regarding the surgery, about 3 to 4 centimeter skin incision is given, and a small craniotomy is made, because the tubular retractor is only about 2 centimeters. So 3 centimeter craniotomy is more than enough. And the 3 sutures are applied on the outer side of the tubular retractor, and the pial stitches are also applied so that the tube does not migrate upward, outward, or inward. The surgery can be performed using endoscope, or if you are not expert in endoscopic surgery, then you can use microscope and the exoscope with the same incision and same tubular retractor of 2 centimeter in diameter. We use 30 centimeter long endoscope, 4 millimeter in diameter, and we use telescope holder so that both of your hands are free and you can do bimanual dissection. So this is a small video of a thalamic tumor. The lesion here in the thalamus, the incision in the superior parietal through the superior parietal lobule. The dura is opened and the pile stitches are taken. So pile stitches allows, it prevents the brain falling away from the dura mater. So 3 pile stitches are applied, and then you can go transcortical or transsulcal, depending upon the anatomy available. This was transcortical incision. The nasal speculum is introduced in closed limb position, and then it is gently dilated. Tubular retractor is passed through it, and then you see that the tumor, the tubular retractor has gone. Even with the help of only a marker CT scan, we have gone dot on the tumor, because most of the cases which require surgery, usually these are large tumors, so you don't miss even if you use marker CT scan. So this is the tumor. The fluid came out and the wall gradually dissected away. And the tumor is removed using bimanual dissection, using normal instruments, and piecemeal dissection, further dissection of the wall. And more piecemeal dissection is performed. And after that, you should go for absolute hemostasis. So absolute hemostasis is performed, and then you irrigate the cavity and remove your tubular retractor. And you can see that the brain is far away from the dura. So, I think this is another video of intraventricular tumor, atrial region. Again, marker CT was done. The tumor choroid plexus. This is marker CT in the center of the lesion. This was choroid plexus papilloma. Small craniotomy. Again, pile stitches so that the brain does not fall away from the dura. And then transcortical approach, introduce the nasal speculum first, and then put in tubular retractor inside this, take out the nasal speculum, and then use telescope holder and station your endoscope at the margin. So the tumor is dissected using a bimanual technique, piecemeal dissection performed, and separated from surrounding tissue. More tumor removed. Then in choroid plexus, you have a vascular pedicle, which was coagulated and cut. And then the other part of the tumor removed. There was some more after the pedicle was devascularized, the rest tumor which was more anteriorly placed also was removed, and then absolute hemostasis and the coagulation of the choroid plexus was done. And after the absolute hemostasis, the drain was left in the ventricle and the complete tumor excision was done. So regarding the results using tubular retractor, we have a vast experience of more than 800 surgeries of intraparenchymal or intraventricular hematoma and deep-seated tumors or intraventricular tumors. Of these, 342 patients were of the tumor. Out of this, 245 were deep-seated parenchymal lesions, and 97 were large intraventricular tumors. Majority of them underwent gross total or near total excision. The complication included some small contusions, although it was very small and none of them required any resurgery because of the soft nature of the tube. Two of them had transient hemiparesis and speech deficit, which improved. So to say that it is safe and effective, the combination of the tubular retractor and endoscope has been used by the other authors, including Dr. Newman. And these are our 3 series in which we use tubular retractor in hematomas and tumors, and we also found it very safe and effective. And there were other authors also, which they also concluded that endoscope and tubular retractors are very effective and safe. This is one such example. You see the large tumor and post-operative complete excision done. Another case, another intraventricular tumor, subependymoma, post-operatively, and another intraventricular tumor, post-op reasonably good excision. This is another example of colloid cyst. I think I will hurriedly go through this. This was a cyst, colloid cyst, same step when nasal speculum, and then you introduce tubular retractor through this, and then you do surgery. This is the colloid cyst, choroid plexus, separation of first the coagulation of the choroid plexus, and then you cut the choroid plexus, separate choroid plexus from the cyst wall, and then you incise the cyst wall, take out the content of the cyst wall, and then try to deliver the cyst in the lateral ventricle using bimanual dissection, coagulate and cut the adhesions from the cyst wall to the roof of the third ventricle. So all these things, using bimanual dissection, you can separate them. So you can see the choroid plexus attached to the cyst wall, which is coagulated and then sharply cut. And after that, the whole cyst can be removed. When you use channel endoscopic surgery, then this kind of dissection is difficult. So at times you just you have to just pull the cyst wall, and you may get hemorrhage and difficulty in surgery. Whereas with the help of tubular retractor, the surgery becomes quite simple. So regarding the approach, we normally have seen that we talk about middle frontal gyrus approach for intraventricular tumor which are in the frontal horn or near the foramen Monroe. But in endoscopy, I use superior frontal approach, and we found that this is better. And it has been supported by the study which was done using two approaches, superior frontal approach versus middle frontal gyrus approach. And they use diffusion tensor tractography to find out how much damage to the white matter tract was done. So both approaches destroyed about 7% of the callosal fibers. The middle frontal gyrus approach disrupted greater number of fibers of allocant neural bundle, that is SLF2, pyramidal tract and cortical reticular tract, and therefore it is regarded inferior to the superior frontal approach. And we have been using this superior frontal approach for all intraventricular tumor which are there in the anterior body of the lateral ventricle near the foramen Monroe and the frontal horn, and this has been found to be very effective. Although you should try and individualize depending upon the DTI and the individual patients. But there are limitations of these surgeries. There could be migration of the tube inside or outside. When you pass instrument, then the tube may come outside or may migrate down. So we came across this problem. So we use these three sutures and which were fixed on the drapes so that it does not allow migration of the tube. The retractor may become unstable after removal of the large tumor, and when there is a huge ventriculomegaly. So when the CSF is drained and when the large tumor is removed, then that tube becomes unstable. It just tends to fall one way or the other. So when you use sutures, that prevents that complication. And when there is a large opening, then you can use larger tube so that it holds the surrounding brain also. The brain may fall away from the dura mater, which also happens when there is a large tumor and huge ventriculomegaly. So to prevent that, we started using piles to sutures, and which prevents brain falling away from the dura mater. The nasal speculum may cause contusions in a tight brain. So initially you should try and make the brain lax. But since the nasal speculum is introduced only for very small duration, and it is a gradual dilatation, so it doesn't also cause any harm. There may be injury in pushing the tube deep. If the tube comes out partially and you want to put it again, if you just push it down, then there may be injury to the brain. So in such case, it is better that you use nasal speculum again and put the tube through the nasal, inside the nasal speculum, and avoid damage to the brain. Tube may get collapsed if it is placed horizontally. We usually think that you can operate the way you want, but since the tube is soft, so if you put the tube horizontally, then the overlying brain will distort the round shape of the tube, and it will be very difficult to work. So therefore, the tube should be at about 90 degree to the floor, or maybe 10 or 20 degree this side or that side. But do not put in tube horizontally to the floor. If you do this, then the overlying brain causes collapse. And the other thing which always one should see, that when you put in tubular retractor, it should be at the center of the tumor. It should not be at the corner. If you put it at the corner and then you try to remove the tumor at site C, then you cannot just push it to that level. Sorry. So it is better to keep it at the center, pour it, and then reduce the size of the tumor from 5 centimeter to maybe 3 centimeters. So when you keep pouring, then the size of the tumor decreases and it comes in front of sorry, it comes in front of your tubular retractor. So keep removing the tumor from the superficial to the depth, and then the 5 centimeter will become 4 centimeter, 3 centimeter, and things will keep coming in front of the tubular retractor, and you don't have to move it to any direction. So don't put in tube at the corner of the tumor. You should be at the center. And obviously, it is not useful when the lesion is superficial. So if the tumor is just at near the bone, then it is of no use, obviously. So for detail, you can read all these publications of ours in the book Neuroendoscopic Surgery, a Comprehensive Approach, where all details are given. So to conclude, deep-seated intraparenchymal or intraventricular brain tumors are difficult to remove due to deep location, and there is difficulty in visualization of the corner, especially when you use microscope. But these things can be overcome by a combination of endoscope and the tubular retractor, and making a trajectory in the long axis of the lesion. And the problem of controlling the bleeding when you use channel endoscopic surgery also can be overcome when you use tubular retractor along with the endoscope. Bimanual dissection is also good. So combination of endoscope and tubular retractor overcomes the limitation of channel endoscopic surgery. Results are good. It is safe and effective, but there is a learning curve. So that finishes my one talk. I think I quickly finished the other part, that is the hypertensive intracerebral hematoma. Are you able to see that?
No,
Dr.
sir.
Swami?
No, sir.
Yeah. So we know, although the role of surgery for deep-seated intracerebral hematoma is
Sir, we want your
controversial.
slides, sir.
Huh?
Slides
Slides are coming, not coming.
not coming, sir.
Okay, okay. So, okay, I think I have to share. Okay.
Yes, sir.
Okay, okay. So again, how to do that? Okay. Okay, share screen and then like this.
Okay, perfect.
Is
Okay,
that all now?
Okay.
Yes,
I think I have to make the slide show. Is that all right now?
Yes,
yes.
sir.
Okay, so the other part is hypertensive intracerebral hematoma. Quickly, because majority of them has been covered. Although the role of surgery for deep-seated intracerebral hematoma is controversial, the recent report using minimally invasive technique have shown benefit of surgery, including our own report of endoscopic surgery on spontaneous basal ganglionic hematoma, and the other authors using minimally invasive technique. The two high-quality randomized trial of 1,033 patients and 601 patients of STITCH trial 1 and 2 have failed to demonstrate any significant benefit of surgery, that is open surgery, as against the conservative treatment. So open surgery was used, the minimally invasive surgery were not used in these cases. There was high morbidity and mortality, but the limitations of these trials, so therefore they cannot be applied now as regard to minimally invasive technique. The limitations were that there was high crossover, more than 20% patient conservative treatment went into the surgical arm, and the open surgery was done, which is likely to cause more damage to the brain. So therefore, the advantage of surgery has been nullified by the damage done because of the open surgery. Although non-significant difference was there, I mean, there were trends towards better outcome in the surgical arm in selected group, and there was the sub-analysis was done by the same group, Professor Mandlo group, and they found that there was a mixing of the patient. So there was a subgroup in which there was a benefit of surgery, and there was a group in which there was a harm. So overall effect was no benefit. So a subgroup of the patient with GCS 10 to 13 or the large ICH are likely to benefit from surgery. This was subsequently reported from the trial. And because there were less number of patients, so if you recruit more patients, possibly that non-significant difference in the conservative and the surgery group may become significant. So these are possible limitations, but we all know that these are three most important prognostic factors in intracerebral hematoma, that is volume of the clot, the GCS at admission, and presence or absence of hydrocephalus. So the lesser is the clot, the better is the prognosis. So if you can reduce the expansion, if you can prevent the expansion of the hematoma by control reduction of BP, blood pressure, and correction of coagulation defect and platelet deficiency, or you can remove the clot, thereby reducing the amount of the clot. In that case, theoretically, there is a possibility of better prognosis. Although you cannot control GCS at admission, but we all know that there is secondary damage, apart from the GCS at admission, the patient continued to deteriorate because of the secondary damage, because of the volume. So if you reduce ICP, if you can take out the hematoma, which will reduce edema and neurotoxicity of the blood, then possibly the secondary damage can be minimized. And then when there is a hydrocephalus, if you treat hydrocephalus, the prognosis becomes better. So there is a subgroup of the patient, and if you do things minimally invasive, which unfortunately was not done in those trials, so those trials cannot be extrapolated now as far as minimally invasive techniques are concerned, but we agree that there is no scientific evidence suggests that surgery has a benefit, because as so far we don't have any trial. So the indication of surgeries are hematoma of 30 centimeter, 30 cc or more, and the GCS between 8 to 13. So if the GCS is very poor, that means 3 to 7, then these patients do not do well. So there is no point in operating in a very poor GCS. The large hematoma reaching the surface, the cerebellar hematoma of 3 centimeter in diameter with the associated hydrocephalus, there is a definite indication for surgery. The contraindication is when there is a small hematoma, the patient is in very poor GCS at the time of ictus, and there is a brainstem hematoma. Japanese Stroke Society also have recommended indication for endoscopic surgery, putaminal hematoma, thalamic, cerebellar, the lobar, although there was no definite guideline, but some of them, they do well. In putaminal hematoma, if the E2 or E3 and the hematoma of 30 ml or more, then in these patients, the surgery is indicated. Thalamic ICH usually have associated IVH and hydrocephalus. So if that is there, then you should operate. Now, there are various methods of treatment of ICH or IVH. The endoscopic surgery, microscopic surgery, thrombolysis, the catheter removal, blind insertion of the catheter and aspirate the clot. So there are advantages and there are limitations. The visualization of the clot and bleeding points can be very well done in the endoscopic surgery and microscopic surgery, but it is not there in thrombolysis or catheter removal. These are blind techniques. So there can be rebleed. So the rebleed, or if there is a spot sign, there are subgroup in which there is a spot sign. So these patients are likely to have enlarging hematomas. So such patients, if you have, then if you do surgery either with the microscope or with the endoscope, then you can you can control that bleeding point and rebleed does not happen. Whereas in thrombolysis or catheter removal, that is not there. So if there is a bleeding, you can control with endoscope and microscope. Percentage of hematoma removal is good, both with endoscope and microscope, but it does not occur in thrombolysis and catheter removal because it takes some time for thrombolysis to remove most of the hematoma. But it has been seen that even if you remove 50% of the clot, it makes difference in the prognosis. So damage to the overlying brain is less in endoscopy, obviously much less in thrombolysis and catheter, but the infection rate is more when there is a foreign body in thrombolysis and catheter. So there are advantages and limitations. The endoscopic technique, you can see that most of them are green. That means there are more advantages compared to the amount of little more damage compared to thrombolysis and catheter removal. So there are better. There are some recent studies done by various authors recently in 2019. Few et al. They studied basal ganglionic ICH of 177 patients, of which endoscopic treatment was done in 61, minimally invasive puncture and drainage in 60, and craniotomy also in almost same. The conclusion was the endoscopy has the advantage of direct vision, efficient hematoma evacuation, and relatively good results. So recent studies favor endoscopic treatment. Another trial that was systematic review of endoscopic treatment, craniotomy, conservative treatment, stereotactic aspiration, in which 18 studies were included, and there were 1,213 patients. And in this also, the conclusion was endoscopic approach had better performance than craniotomy and conservative in terms of reducing mortality, dependence, and specific complication. In another study by Lee et al. Of 2017, where craniotomy, endoscopy, and stereotactic aspiration was done in a spontaneous supratentorial lobar ICH, and they also found that stereotactic aspiration and endoscopic possess advantage over craniotomy. The endoscopic surgery might be more safe and effective with higher evacuation rate, better functional neurological outcome, and lower complication rate and mortality. Again, another Guo et al. Compared endoscopy, craniotomy, and stereotactic aspiration in large number of patients, 516, and they also found that endoscopic aspiration can decrease 6-month mortality of spontaneous basal ganglionic hemorrhage, especially in patients with hematoma volume of 40 ml or more. There is a trial going on in which they randomized control trial comparison of endoscopy versus stereotactic aspiration and craniotomy for supratentorial hypertensive ICH. So this will address all the questions, but the results have not come yet. There were many studies of endoscopic treatment of ICH, including our own, which we reported in 2018 of 270 patients by endoscope and using tubular retractor. So we found favorable results. I think I skipped this tubular retractor. We have already discussed. There are many tubular retractors available in the market, including the syringe and the other retractors, but you can imagine the soft tube, silicone tube with the cut inside has the advantage. Now, regarding the size of the tubular retractor, many people have used different diameters ranging from 11 millimeter to 20 millimeter. So they, when up to 11 millimeter, they think that it is all right, but you know, in 11 millimeter tube, you have to introduce endoscope, which may be 3 to 4 millimeter in diameter, and the 2 more instruments, one suction, you need bimanual dissection. So 2 more instruments. So then it becomes difficult to manipulate the 2 instruments in that tube. But if you have a instrument with angle tip, then you don't require any linear movement. So you need a special instrument when you have small tube, that is angle tip instrument, 2-in-1 function, in which the suction with coagulation is combined, so that with one instrument you can do many works. The advantage of tubular retractor we have already dealt. I have already said that you mark the center of the lesion, hematoma or the tumor, and then decide steps you already know. It should be along the long axis, put in nasal speculum, then introduce tubular retractor, and then with the endoscope do the surgery. So a small clip of intracerebral hematoma. This was left side basal ganglionic hematoma. This was the planning, this was the hematoma, and center of this is tubular retractor. So you direct your tubular retractor towards the center of the clot. So tubular retractor was introduced, and then under the endoscopic control, the hematoma is removed, even with the normal suction. And if there is a raised ICP, the tube gets collapsed. So initially, this tube usually remains about 11 or 12 millimeter, and then gradually, when the ICP is decreased, when you remove hematoma, it expands. So with bimanual dissection, you can remove the clot and can also hemostasis at the mark using bimanual dissection. There were some sort of micro aneurysm abnormal vessels. So we coagulated those abnormal vessels and then cut it. So absolute hemostasis can be performed because you can see well. So these were some abnormal vessels which were removed, and then you can lay over this hemostatic agent. And so after absolute hemostasis, it is closed. The fluid is introduced, take out the, and this is post-op showing good hematoma removal. So important step which I want to stress is that if this is the clot, then you should land your tubular retractor at the middle of this clot. Don't be at the surface of this and take out the whole hematoma. If you remain at the surface of this and remove the hematoma, and because there will be raised ICP, so the moment you remove this superficial portion of the hematoma, the surrounding brain will collapse and the visualization of the distal hematoma cavity will not be there. So go at the middle of the hematoma, take out the distal portion of the hematoma first. So take out the distal hematoma, gradually come out and remove the proximal part. Otherwise, the distal hematoma may remain trapped because of the prolapse of the normal brain, and you may miss the hematoma. And after the surgery, you find that 50% of the hematoma have been left out. So these are pre-op and post-op. These are some of the publications. So to conclude, endoscopic approach using tubular retractor allows better visualization and it allows perfect hemostasis, unlike the aspiration or thrombolysis. And there's a more percentage of hematoma removal, rather almost 100% hematoma removal can be done without causing damage to the overlying brain. So overlying brain is not damaged, the hematoma is removed without significant risk of rebleed, because you can coagulate the bleeding vessel, and without the significant risk of infection, because you don't put in any foreign body for 3, 4, 5 days. in thrombolysis and in catheter drainage, you leave that catheter for some time, which may produce chances of infection, and there may be rebleed because you don't control that bleeding point, the spot sign, but it is technically demanding. Although keyhole microsurgery with or without tubular retractor also can be done. So I agree that you can do it with the endoscope. You can also do it with the microscope. But the endoscope allows little better visualization of the corner. So if you learn endoscopy, it is to microscopy. Stereotactic is all minimally invasive, but it does not allow quick removal of the clot, and it is risk of infection because the catheter has been left there. There is no benefit of thrombolysis over conservative treatment in the MISTI 3 trial. But I think Ju et al. Trial is going on, which have randomized comparison of endoscopy versus stereotactic aspiration and craniotomy. So this will address the issue better in time to come. Thank you very much. Thanks.
Thank you, sir. As usual, next excellent presentation. You have given extensive review of how to devise a tubular retractor with available local material in to the world. If I want to say, this tubular retractor, which Professor Yadav has revised, costs just around, say, 1 cent in USD dollars. So such is the innovation, and it's available everywhere, very modified. And you've given how exactly to remove the approaches for the deep tumor as well as for the hematoma, which is inside, without causing collateral damage, the advantages of it and the disadvantages of it, the various tubular retractor available, and the advantage of your tubular retractor over the others, where I'm also honored to have Dr. Shailendra Ratre as panelist. Dr. Shailendra Ratre works in Jabalpur and is an enthusiastic endoscopic neurosurgeon. It was quite unassuming, but then such a wonderful neurosurgeon. Okay, and we are, in fact, you yourself have introduced, sir, Dr. Avdesh Jaiswal, who does without retractor. So we have one person who does exactly, as you said, many ways of doing it. One person who does without tubular retractor, and one person who has developed a very good method of a tubular retractor and removing a deep-seated brain tumor. Welcome, Dr. Avdesh Jaiswal and Dr. Jitin Batan. Welcome as a panelist. May I ask the panelists to have the comments?
Sir, as usual, this presentation was extremely good, and it covered all the aspect of this minimally invasive approach for this deep-seated tumors as well as hematoma. Actually, I just want to ask, sir, do you use any holder or some assistant holds the scope for you?
I use holders. I just want to say that Dr. Avdesh Jaiswal doesn't use any tubular retractor, and it is excellent. So we should always listen to each other, and there are good points and there are things you can do it differently. So he does it excellently well without a retractor. So there are other ways. Regarding your answer, I use telescope holder. I don't find any problem in, because some people say that the advantage of endoscope is the dynamic nature when you introduce it. And so even in the nasal surgery, pituitary, craniopharyngioma, all these things, I use the endoscope holder. And the reason is because I had no other choice. There was no one to hold a scope for me. And now I think I'm used to it, and I can say that now, because these people are available to hold a scope for me, I still don't prefer somebody holding a scope for me. And the endoscope does it better than the assistant holding a scope. except in situation when there is a brisk bleeding and you may have blood which is staining your scope. In that case, you can ask your assistant to hold the scope for you.
So how don't you feel any problem in the depth perception?
No, yes, this is, see, there is always a learning curve. What I do is that I use the angle tip instruments. So the angle tip instrument allows always the tip to be visualized, number one. And then you should always observe your instrument in relation to the surrounding structures. So there is a problem of depth perception, but if you relate your tip of the instrument with the surrounding structures, then you can, I have never what you call it, unnecessary penetrated the surface or something like that. And I did not take time to reach at the target area where you want to work. So you relate the tip of your instrument with the surrounding structures, and taking help of that clue, I think the 2D, 3D business has not, actually, I don't use 3D endoscope, and still I don't find any problem of 2D, 3D. Yeah,
I think
but
this must have happened because you have operated so many cases that what you see actually in 2D, it works in your brain like 3D. So it may be a reason because of this. But how often you change do you need to change the position of the endoscope frequently to see this place along with using the holder, or you keep it fixed throughout the surgery?
No. The basic principle, I think I'll discuss this also. When you work cranially, your endoscope should be stationed cranially. Anteriorly, then it should be stationed. If your endoscope is stationed cranially and then you work caudally, there will be blind areas. So when I work cranially, then I station endoscope cranially. When I work on the right side, then I station my endoscope on that corner on the right side. On left side, then in the direction in which you are working, the endoscope should be there. And also the direction of the tubular retractor also should be in the same direction. Then you can do better surgery.
So basically,
I keep changing, yes. But it doesn't, not every moment. I first do work towards the one corner, finish that, and then change the telescope direction in another and third. During surgery, 3-4 times only, not so frequently.
So which retractor do you use, sir? Pneumatic or articulated one, manual?
Retractor means which
holder?
Articulated.
Stores articulated, stores holder. It is not pneumatic, it is mechanical. There is a knob, you just tie it. Yeah.
So, and other thing that do you do before using the nasal speculum, do you do some amount of corticectomy to make the cortical tract?
Yes, obviously. I make a tract. Obviously, you cannot just push the nasal speculum there. So using 2 instruments, one suction and a little bit of corticectomy, and create a tract there. And then I introduce my nasal speculum in a closed limb position. It is a tapered nasal speculum. So somebody also asked this question. So do a little bit of dissection, little bit of corticectomy, and then with the 2 micro instrument, I make the tract, and then put in the nasal speculum in the closed limb position, which is also again tapered.
So actually, there are 3 reasons why I do not use. In fact, truly speaking, I have never used and I have no experience with the tubular retractor. So number 1, that the tubular retractor provides continuous pressure over the adjoining brain. While in our case, we use an endoscope and a suction in one hand one corner and the operating instrument, dissector, bipolar or whatsoever in other hand. So all these three instruments, they provide dynamic traction.
Dynamic
Dynamic traction. So this is the
Absolutely.
principle, and this is a freehand technique. The other thing that I think your tubular retractor must be some part is outside dura. It has to be some part outside dura.
Little bit,
So,
yes.
so this will increase it. I think this will increase the depth of the operating surgery. Already you are operating in a depth. Some amount the depth will increase. And the third thing that the surgical freedom will be limited with the diameter of the tubular retractor. If you do not have retractor, so the freedom will be a little more, I think. So these are the three things that I think. What is your comment about this, sir?
Yeah. So I'll answer one by one. One thing is that the tubular retractor causes pressure on the brain. I agree with the other tubular retractor, it is there because
Of course, yes.
These are stiff tubular retractor. Our tubular retractor is a silicon tube of 1.5 millimeter in thickness, which is very soft. So it gets collapsed itself rather than putting any pressure on the brain. And therefore, the chances of contusions in our series are almost nil. Okay, so this thing. Two is that you should never ever use a tubular retractor of oversize. If you keep it oversized, then obviously it increases the depth. So the tubular retractor depth should be at the level of the dura, just up to the level of the dura, so it does not cause any problem. And I keep tagged sutures there. And the third thing is, you said that obviously it hinders your movement. So when I work on the right side, then I also direct my tubular retractor slightly on the right side. So not that it is 2 centimeters, but when you work on one corner, then you angulate it with your suction tube. The suction tube itself pushes the tubular retractor cranially, caudally, right, left, the way you want. So it's a dynamic retraction, and it allows 2 centimeter corridor, constant corridor, every time you work. And I know, yes, the way you keep doing this is how you start liking things. But this is one way. Yours is also one way. Dynamic retraction, absolutely correct.
Actually, the biggest disadvantage of doing freehand technique, which I personally perform in our center, is to maintain the cortical tract, which is maintained with. This is the advantage of tubular. I completely agree, sir.
Yes, so you don't have to struggle to this thing. And since the tubular retractor is soft and you can go in any direction, it allows it protects brain, it allows the patent tract without causing any harm to the brain. So this is one way of doing. I agree there are other ways. You do it excellently well. Yes.
See, I believe that the goal of surgery should never be compromised, whatever way you do it. It should never be compromised. If somebody is comfortable with some approach, he should do it. But the goal of surgery should be never compromised.
Yeah,
anyway,
removal of 50% tumor using endoscope is useless. So
yes.
if you remove 100%, whether you use, 100% means as much as safely possible with microscope or endoscope is better. But since it is endoscope is a recent technique, it is better. So all of us should learn gradually. Yeah.
But I think that if somebody want to venture in these techniques, they should be comfortable with the microscopic surgery first, because this is a microscopic surgery under endoscopic vision. So it's an endomicrosurgery. The surgical principle is microneurosurgical.
Correct.
Anyway,
Absolutely.
good lecture, sir. I really enjoyed it, and I think we can discuss this thing. But definitely very good technique. And I think in some cases I will use this retractor and let us see how it looks like. Thank you, sir.
Yes.
Right. If I may add on.
Thank you for your comments. Excellent. Yes.
Whereas even a slit, then it acts as, like not a limited aperture.
Swami, Professor Swami, your voice is breaking, I think. Professor Swami, your voice.
Yes, yes, sir.
Yeah.
Yeah, I think other panelists can explain in the sense there is no particle damage. If you are using free hand technique, you have to every time you have to press on the cortex.
Some network issue is there, sir.
Yeah, please take on the questions.
I think, Dr. Swami, your voice is breaking. So they are not able to listen. Dr.
Can we
Radhe
take
is
question?
coming?
Yes, sir. Can we take questions, sir?
Yes, yes.
Go
Meanwhile,
ahead,
we can.
go ahead, try it, Dr. Ratri.
Yes, sir. So there is a question, sir, from Dr. Rahul, that what are the chances of brain contusion due to nasal speculum?
Yes, I have already discussed that since it is a stiff, but the duration of retraction is very short duration. See, so therefore, and it is a gradual retraction. So we don't come across, although we have seen some cases, small contusion, but in never in none of the cases we have to go in. The contusion was not significant in any of these cases. But if you find a tight brain, it is better to relax the brain by taking out the CSF, or if it is a hematoma, remove it little bit so that the brain becomes lax, and then only you try and retract the brain. Otherwise, you can produce contusion. The principle remains same. So retract brain when it is little bit lax. And overall, when you go in, what happens in hematoma when you go in, then 50% of the clot comes out of its own. So it gets relaxed. In hematoma, there is no problem. In intraventricular surgery also, there is no problem. The moment you enter the ventricle, the CSF comes and then everything is relaxed. But if you have a deep-seated parenchymal tumor, and then you use this, then you have to be little careful. Yes.
So, sir, there is one more question by Dr. Pratosh. But you have given the explanation. The question was, what is the technique to introduce the nasal speculum? Can it may lead to contusion during insertion? So you have already explained we have to lag the brain by removing hematoma or a small amount of CSF.
Yeah, and initially, I think I did not tell this, that initially you have to use 2 micro instrument to make a tract.
Yes,
I mean,
yes.
up to the pathology, and then you introduce nasal speculum in a closed limb position. You cannot open it. So both the limbs are closed. You introduce it gradually, then you gently enlarge the opening, and then put the tubular retractor and take out the nasal speculum. So the duration of nasal speculum is very short. It may be in some maybe 20 seconds or less than that. So most of the time it is the soft silicone tube which is retracting the brain, and not the nasal speculum.
And another question is about the sterilization of the tubular retractor. So we do ETO.
Yeah, and you can autoclave also. Silicone can be autoclaved. So in you can autoclave, ETO, all these things can be done. Silicone tube is not damaged by doing autoclaving.
And sir, one more question is from Dr. Jakaria, that what's your opinion about enrich study?
Enrich study. I'm sorry, I'm not aware of this. Enrich. I am not aware of that study.
So one more question is, sir, what is the ideal timing of operating endoscopically in putaminal bleed? So
Yes, I have come across people talking that if you delay surgery, the clot becomes firm, or some talk about it becomes soft. So it doesn't matter. See, because you are not sucking out through the catheter. It may be important when you use suction, stereotactic aspiration or catheter aspiration, because that the solid clot does not come through the catheter. But when you are using endoscope and doing a bimanual dissection, it doesn't matter. Whenever, so operate as early as possible. There is no question of delaying or timing of surgery as early as when it is indicated, because you don't aspirate. You do a bimanual dissection and you take out solid clot, whatever it is, fragment it and take it out.
sir, one more question is, what type of scope should you use, 0 degree or 30 degree?
Yeah, 0 degree scope, but it can be, you can use 30 degree also. If you think that the visualization of the corner is not good, then you can use, but I use 0 degree in 95% of cases, and I angulate it. So if you use 0 degree scope and you angulate it to the right, left, cranial, caudal, then it becomes some angled scope also. So most of the time you don't require any change of the scope.
Yes, sir. So one query is from Dr. Joanne is, what is the best hemostasis technique after hematoma removal?
What is?
The best technique of hemostasis. How do we do hemostasis most of the time?
Yeah, whatever is required, if there is just a small little oozing, you just use hemostatic agent and it stops oozing. But if you think that there is some vessel from where it is bleeding, so coagulate it. I use bipolar forceps, the endoscopic bipolar or a usual bipolar, using this tubular retractor. Even you must have seen that the normal bipolar can be used through that 2 centimeter tubular retractor.
Yes, sir. So one more question is, sir, how to avoid the fogging during the surgery? Fogging
Yes.
of scope.
Yes, it is there. The fogging, causes of foggings are many. Usually it is either because of the humid environment when you keep operating, and if you don't suck the air there, the media, the humidity is one cause, and you just suck the air and it becomes clear. The other cause of fogging may be some fluid, irrigation fluid is coming on to the tip of the endoscope. So just bring your suction tube near the tip of the endoscope and it clears. And the third cause may be that the endoscope tip touches the tubular retractor or the brain surface or something, or when you remove your hematoma or the tumor, the part of the tumor touches the endoscope tip. So that causes blurring. So just irrigate it, either take it out, clean it, and then introduce, or just irrigate with the saline and it becomes clear. The another cause of blurred vision during surgery is the wrong placement of the endoscope. When you are working towards the right side, the endoscope also should be directed towards the right side. If you do it on the other side, in the endoscope, sorry, the margins are not seen so well. So, I mean, change the direction of your endoscope, the vision improves.
Yes. And sir, one more suggestion that can we use this balloon dilatation of while making the trajectory instead of nasal speculum?
Yes, yes, it is there. People use it, balloon plus, I think so many people, Dr. Lokendra Singh uses balloon. It is quite good. I mean, balloon and inflate it, so it makes the tract. There are ways. Yes, we agree. But this also, the nasal speculum does not cause any harm. We have been using it for many years. But in tight brain, yes. So whatever you do, whether you use balloon or nasal speculum, in a tight brain, it will hurt. If it is a lax brain, it will not.
So the questions are over, sir. No more.
Okay, I think we have a comment from Harshad Parekh, the eminent neurosurgeon from Mumbai. Welcome, Harshad.
Hi. Hello, Professor. How are you?
Sir, I'm fine, sir.
Excellent talk as usual, as always. Very enriched with a lot of pulse of wisdom and a lot of learning from all your talks. And you're doing a great job to the community. There are few points which I would like to highlight. One thing is, yes, without a navigation, you can just use a marker, either on MRI or a CT scan, and you are bang on that, and you can get a track. And we are doing this since many years. I use for a MRI vitamin D marker, or sometimes this capsule which we use for the blood pressure control, and it takes us, vitamin, and it gives you a very good thing. And even when I'm using navigation, I still do a preoperative marking, so that navigation is confirming that. So it is very helpful. That technique is very good. Regarding this Lokendra Singh's technique, you are saying, what we do on a brain cannula, Dandy's cannula, you put a glove finger and tie it and put a water inside and keep on increasing, and that enlarges your incision. Most of the time, what we do is we go through the sulcus, and through the sulcus, rather than, so that brain contusion and all these problems can be avoided. But your retractor, I have used it and it works very well, no doubt about it. And endoscopy really gives you a chance to go through the lateral side of your tract trajectory. You can easily see very well, which many times microscope can miss it. Very good point you have suggested when you are removing a hematoma is go into center of hematoma first, otherwise you will miss it. Yes, I agree. We do see it. And post-operatively, you see some hematoma is left behind. Yeah, wonderful technique. And both I think tumor removal and a clot removal remains more or less same technique, whether deep-seated I'm talking about. The same endoscopically you are doing. Endoscope really helps to give you light and depth perception also. Wonderful. Agreed. Thank you.
Sir, thank you, sir. Thank you, sir.
Am I audible, sir?
Yes,
Hello?
sir.
Am I audible?
Yes, sir. Yes, sir. Yes, sir. You are audible. But so there is some interruption.
Okay.
So there is interruption of there. So, sir, there, Dr. Jitin is also.
Thank you, sir,
So,
for an
sir,
excellent presentation. Thank you, sir, for an excellent presentation. So, as a younger person, sir, no questions. I've assisted you for long, sir. Younger person, I have 3 comments, sir. First thing, I have never seen a retractor-associated edema with the tubular retractor. I mean, you are operating for long cases also, 2 hours, 3 hours with continuous this retractor. Never ever saw retractor-induced edema, which is sometimes seen with the fixed Lela retractor. So that may be because of the dynamicity of the and softness of the retractor. People often think that tubular retractor is a fixed circular tube, but it is actually a dynamic thing. We often tilt the retractor to one side, and sometimes with the brain pulsation, the retractor also moves. Second, as a younger person, the problem of soiling with the touching of the endoscope to the walls of the cavity, that soiling is taken off with the tubular retractor. I mean, and third part, another very important thing is whenever we are passing our instruments, so there is an area which is blind, which is proximal to the endoscope. And in the initial part of our career, we sometimes injure the brain, and with the tubular retractor, we pass it safely inside and out. Thank you, sir.
Yes, excellent point. I mean, the other advantage is blind area, no brain damage, and it protects soiling. Yes, correct.
And sir, one more important advantage is that this retractor helps in hemostasis. When there is bleeding, we can push to the bleeding points, and we are very comfortable at that time while removing the tumor, especially.
Yes, yes.
So, a very nice presentation, sir. We are thankful for this lovely presentation, and all the points are very well covered, especially for the younger generation. And thank you, sir.
Thank you. Thank you. So I think Dr. Swami summarize, and then John sir to finish.
The sir voice is, there is some problem, sir.
I think Dr. Swami, your network issue. So I think things
Yes,
have
sir.
been
Yes, sir.
covered.
Yes, sir. There are no more questions.
So John sir, over to you.
Okay, very good. Good interaction. What do you think, Dr. Yadav? Good interaction, right?
Yes, yes.
Yeah, yeah.
Yeah, excellent interaction, good panelist, and very good people listening. And that is what I think is important. Interaction, if it is good, then we enjoy things. Things become better, clear also.
Okay.
Thank you.
What are you going to cover next week, Doc? Did you see it? Did we see it, Narayan? Anyways, it's on the schedule. That's okay. It's on the banner for the webcast. And so we look forward to another week of good interaction next Sunday. Thank you, everyone, for coming. And thank you, Narayan, for moderating, Shalandra, and Jitin. Jitin, you have a great background. You see how it can make it look good? I mean, your background's dynamite. Thank you very much. Okay, we'll see you next week. Stick around if you want to network.
Thank you, sir.
Thank you. Bye. Yeah. Thank you.